And so as we begin the panel discussion, maybe we just have a quick introductory session. And Diane, I do apologise, Diane, I've missed you there in the corner. If we could maybe just do a quick introduction to one another, to each other, and then we'll move on with the questions. So Diane.
Yeah, thanks, Anna. So I'm one of the AAPE members. I'm an advanced physiotherapy practitioner, and I also work part-time as an advanced practice educator at Manchester Metropolitan University. So I'm really excited and feeling really empowered. Thank you, Deborah, after your amazing speech. So thank you.
Thanks, Diane. We'll move on to Marianne. Thank you.
Hi, I'm Marianne Jenkins. I'm a consultant nurse practitioner on a background of being an advanced nurse practitioner about 10 years or so prior to that. And I've got a background of working in adults and paediatrics. I'm currently working in the emergency department, and I'm quite honoured to be invited to be on this expert panel. And I apologise for any background noise. I am in a coffee shop in Tesco's. Sorry.
Thank you, Marianne. Thank you so much. Deborah, I'll skip over you if that's all right,
Yeah,
and we'll move
absolutely.
on to Annabella.
Good morning, and yes, thank you for inviting me to be on this panel. So I'm Annabella Gloucester. I have spent quite a number of years working as an educator in advanced practice, and I'm now the Northwest Regional Faculty Lead for Advancing Practice, working for Health Education England.
Thanks, Annabella. And Paul.
Yep, thank you. Thanks again for the invite. My name is Paul Forsyth. My background is I've worked as an advanced pharmacist in heart failure for about 18 years. I've recently credentialed at consultant level, and I'm helping Scotland with their pharmacy work streams around advanced and consultant for all types of pharmacy just now. So delighted again to be here. Thank you.
Thank you, Paul. And I'm Anna Jones. I'm the Deputy Chair of AAPE. I'm also an educator at Cardiff University School of Healthcare Sciences. And my colleague here is...
I'm Colette Henderson, and I'm one of the Scottish representatives on AAPE UK. So thank you.
Great. So we'll make a start on the questions if that's okay. And so we have one in from Marie about how can we formalise workplace learning rather than it being ad hoc. And so maybe if I start with somebody who's still in clinical practice, Diane, and then we'll move through the panel that way, if that's all right. Thank you.
Yeah, I guess I think Deborah sort of touched on it in her last presentation. Really, I think job planning is an issue. I think in practice, and the clinicians in practice will recognise this, that obviously the challenges are, there's waiting lists. We've got the challenges, particularly post-COVID, of restoring services, long waiting lists. So the thing that usually goes is the non-clinical. Is the non-clinical. So we usually end up being quite clinical focused. So I think really job planning. I also think the accreditation, the verification of being an advanced practitioner and actually having to say that we're working across the 4 pillars of practice, achieving the capabilities, because we're having to do that, it is going to have to be built into our job plans moving forward. So I think there's loads of developments, but I think that's a real step in the right direction. We can't verify and say that we're working of meeting the capabilities of the multi-professional framework unless our job plan allows us to do that. So I think that having that capability framework, the requirement for verification, will mean that our job plans need to align to enable us to fulfill that. And I think once we get to that place, hopefully it'll become more embedded as practice. So I see that we're in a bit of a transition at the moment.
Thanks, Diane. Is there anybody else who would like to respond to that question? Paul, could I call on you? Sorry, Deb. Yeah, please do.
Yeah, no, Paul, you go ahead.
I agree with both speakers so far. I think this does come down to job planning. I think actually regardless of your profession, regardless of your role, actually, whether you're advanced or not, there's something to be said that nobody probably should clinically practice 100% of their time. just not really able to maintain professionalism and competence in any role if that's the case. And I think we're on a generational move towards all of us having job plans. And I think the nice part about these conferences is to come together in a multi-professional sense and say that together. And I really like what Deborah said about registration as well. This is about your regulatory values. It's values normally that keep you on the register, actually doing the right thing for the patient, for your colleagues, for your service, for the population. And the right thing to do here is to educate, is to train juniors, is to have time for other things. And letting those slips actually isn't really an option anymore. And I think we need to dig our heels in a little bit that collectively together to come up and say those things, because I think within each profession we're having the same fights. And I see it in Glasgow and my colleagues, both in pharmacy and the other professions, having the same fights within their own profession. And I think the voice of bringing that and sort of job planning and stuff together brings a lot more credibility and weight to it. So I agree with the panel so far.
Thank you, Paul. Debs, would you like to add to that?
I was just going to build on something Diane said about, when we're busy. And that was one of the things that made me look at supervision in the beginning, because it's the one thing our professional bodies tell us we should be doing. And it's the one thing that drops off very quickly when we're under pressure in practice. But I think we have a conflict between the education pillar, which I didn't talk about today because I wanted to talk about how we can launch, but there's a conflict between education metrics and the productivity metrics of the workplaces that we're in. They're at odds with one another. And I think if we were smart, we'd start to look at what are the learning components that ensure those productivity metrics land, because it's those productivity metrics that keep your trust boards, your provider organisation boards awake at night. And if we could articulate that learning component, I think we might have a stronger voice, and I think we might be heard.
Indeed. There is definitely good advice there for us. Colette, can I hand over to you?
Yep. So next question for the panel. Are there any specific learning points or points of reflection that you can draw on to provide guidance on how to embed the pillars into practice? And that question's open to anyone. Marianne, did you want to say something?
Yeah, I think it's one of the things that I've tried to embed with any trainees that I've supervised is actually get into really good habits. I try to look at things from a very practical point of view, because most of us, when we start off, we're not quite sure what we should be doing and what does our portfolio look. How do you evidence your education pillar? It's really good to listen to Diane's talk about all the key aspects of that side of it. But if you think of trying to, how do you evidence your research and audit pillar when you're working in practice and you're clinically focused, you're not job planned, and it's trying to map those things out. So I do a lot of talking with my trainees about what that evidence could look like, and how do you then pull it through. So it's looking at how you sometimes use in research with the patients, and picking up from the previous point about your practice being ad hoc or your education being ad hoc. I think we work in such clinically rich environments. There's so much to learn in what we're doing, but it's then triangulating that evidence back into the other pillars of your practice. So it's, have you looked at new research that you're then applying in your clinical practice? What does that research look like? Which journal club have you been part of that is teaching you to appraise research that's part of then your clinical practice? And it's trying to triangulate those bits. One of the other pieces of advice I tend to give trainees is actually start early with your portfolio and carve away time each week and to keep fulfilling all of that. So once you get into the good practice and habits, you can start seeing those added evidence from your day-to-day work that you can then map across in a more easier, sort of practical way.
Thanks, Marianne. Annabella, I wondered if you wanted to add something on.
Yeah, absolutely. Thank you. I think sometimes when we think about the four pillars of advanced practice, we think that they're all at the same height and at the same level. And I think it's a continuum, and it varies depending on what's occurring in clinical practice for you individually as a practitioner at that time. Um, and it's sometimes it's just the small steps. So, it could be for the next, I don't know, couple of months, the research pillar is actually really quite low, and it's about integrating that evidence-based practice, but it's also about um, not just accepting practice, but looking for the challenges when things can be improved, as opposed to kind of at the top of the game being a principal investigator and leading some, primary led research. So it can be different for many individuals, and I think we need to recognise that. Likewise, many people struggle with, for example, the research pillar and say, I've got no time for that. But just going back to a point that Marianne said, there's no reason why you can't start a journal club or be a part of a journal club, or if you're aware of, a colleague who's undertaking some research, asking for some mentorship and just, developing your own journey through that pillar in that manner. So I think sometimes it's about grasping opportunities, critically appraising a guideline, utilizing some of the skills you might have undertaken as part of your master's program, for example, but actually beginning to apply that and use that in practice. And likewise for the educational pillar, again, looking for those opportunities. So sometimes it feels very comfortable to do what you're happy doing, which is predominantly that clinical focus, but it might be that stretch in terms of pushing yourself and putting yourself forward when you hear about opportunities to, for example, join a master's in advanced clinical practice team, to use some opportunities as alumni, to even become a lecturer practitioner and develop yourself even further within that educational pillar. So I think the key message is everybody's probably doing bits, but at different points in their career journey.
Thanks, Annabella, and I agree, some really good opportunities to link in with colleagues in HAIs, whether it's as a lecturer practitioner or just to link in to get support to develop some of your ideas as well. I think really important to do that, to make those connections. So we have another question here to the panel from Karen. So do you feel that some or different professions do this better? So, for example, do they embed the visibility of the pillars into practice better than others? Diane, I'm going to ask you that question, if that's okay.
Yeah, excuse me. Yeah, no, a good question. I don't know. I always wonder with advanced practice, and I'm talking a little bit with them about the HPs later. What is the difference between an AHP advanced practitioner and nurse practitioner, and is there much difference, or is it around the clinical specialism of the role that's the difference? I wonder if it's not necessarily to do with the profession. This is just my thoughts, and whether it's more to do with the educational journey to advanced practice. So I guess if you've done a traditional advanced practice masters across the four pillars of practice and you've had education training, then I guess you may have had some formal education training so it might be more at the forefront of your thoughts and your practice. So for me, I'm a physio practitioner of many years. So my journey to advanced practice has been what I would say through a portfolio route. So lots of experiential learning, masters in a clinical specialism, and building up my pillars over time. So my natural journey of training without me being in education wouldn't have included formal education training. So I just wonder whether it's not to do with the professions, but maybe the educational route that you've taken and the educational opportunities you've had exposure to. I don't know if that answers that question.
Oh, no, I think it does. Thank you, Diane. I don't know if anybody on the panel has anything else they want to add. Yep, Deborah, on you go.
I could probably talk about all of these things. To be fair, you've lit the blue touch paper. I'm off now. I think this is back to our pre-registration education as well. So our starting points are quite different and the curricula are quite different. So if you've done occupational therapy or speech and language therapy, you perhaps have some of the more transferable psychology and sociology that makes you maybe a bit more aware of, you've covered some of the theory that we might come to in an education pillar, for example, as compared with, I don't know, pharmacists or maybe physios or one of the other professions. So I don't think we're explicit enough in the pre-registration curriculum about the pillars. And so when people come into practice in early career, they expect only to populate their clinical pillar in order to advance. And so I think we need to encourage much more balance across the pillars from early career. And I think this answers the embedding question as well. And I also think we need to keep that focus on patient benefit as well. It's not just about, so how are these different pillars influencing the patient experience that when I'm working with them? But yeah, I think there's a lot for me. There's a lot we need to do with the pre-registration curriculum and early career, so that when we come to advanced practice development, it's not and there are these other pillars. So how come I didn't know about those before?
That's really good points. Thank you, Deborah. Did anybody have anything else they wanted to add to that? Now I'm going to move to a next question. It's slightly out of the order that we've got there, but I'm going specifically to ask Paul about professional agency. I've heard you talking about this before, and I just wondered if you could explain to us what that means and what your thoughts are about professional agency, please.
Sure. So thanks for the question, first of all. So it's something as an individual I've become really interested in the last few years, but let's try and explain why. So we've already touched on it with a few of the speakers there. It's common, especially in your early career, for people to say, look, Paul, I just want to see patients. I don't really get this leadership or this research thing. Both of those things might be a little bit toxic to me. I just like the patients. And there's a problem with that. And the problem is, if you don't want to lead and if you don't want to do new things, which is what research is, you have to give those rights up to someone else in your department and say, I'll divorce those responsibilities to a different person. And when that happens, often those other people make decisions that maybe aren't in the best interests of you, your patients, your team, your service, and you've given up the control to it. And actually, that's professionalism. Professionalism isn't about me knowing about ACE inhibitors or beta blockers or ECGs. It's about me trying to do the right thing for the patient in front of me, for my service, for my colleagues, for the population. So agency is this concept that you need leadership and research skills to facilitate really you becoming a professional. And it isn't this thing that you can learn overnight, that you get to a band agenda for change certain level and suddenly you need the agency and research and leadership. It's something that you have to learn over a whole spectrum. But they are the skills that allow you to put your hand in there and say, my service isn't quite working here, it's not quite right. So I'm going to put my hand in there, that's leadership. And I'm going to try something new to see if something's better. And that is research. Now, research is quite loaded. Everybody thinks it's the New England Journal of Medicine and the Lancet. I mean, it can be, and it should be for half of a 1%. But for most people, we're talking about service-based research, in my view. What do my patients need? What is my population not getting that they should? How is my service meeting the need for that? And how are we adapting the future to make those things better? Those things are leadership and research, and those things together are professional agency. So there's two components to it. This is the last thing that I'll say. We have to breed the skills in people, so you have to know how to kind of do some of these things. But it is cultural as well. So I can train any of you guys as much as I like on research, but if your department don't let you try new things, then you have a problem. So there are components to this which is developmental, but there's components to this that are environmental. And we're living in a system where our hierarchies within our professions probably strangle some of these things a little bit just now. And we need to move slightly to more a distributed model where everybody leads from the day one that you come out of university, every nurse, every HP, every pharmacist has leadership and trying new things, responsibilities. And that's grown over a spectrum, not given to you at a certain agenda for change band. So it's fascinating this because it will be a cultural change in all of our professionals. And there'll be a generation that have to live with both of these roles in parallel while they kind of fight between each other a little bit. So it's going to be hard, but I think we all think that it's the right thing for us to do. And that's what makes us a profession. So that's what professional agency is. It's about why you're not just a task doer. You're there to do the right things for the patients. I'll send a tweet out about it as the other people talk about what it is. Thank you.
Thanks, Paul. Did anybody have anything else they wanted to add on that topic? Nope. We can move on.
Shall I take the next question? Yeah.
There we go.
So we have, thanks, Colette. We have a question here from Andrew Mundy. And it's quite a lengthy question, so bear with me. But there's some really key points in here that it would be good to hear your opinions on. So what is the panel's view on the omni-professional title / role of ACP, maintaining professional identity and its added value? And could the advertisement of resources targeting purely this role disadvantage other advanced practitioners and limit sharing of knowledge / learning? So maybe if I could start with Annabella, and we'll move around the panel. Thank you.
Okay. I was just rereading the question. So
Quite lengthy.
it is, yeah. I think it's vitally important that we maintain professional identity, both from a profession perspective, but also for patients as well. They need to know who it is they're seeing, and they need to understand actually, is it Diane, the advanced practitioner who's a physiotherapist, or Marianne, for example. So I think it's vitally important that that professional identity is maintained. And again, for me, that always brings through the added value. So whilst there might be a generic curricula that a trainee is undertaking, actually it's the profession and the lens in which they view their practice and deliver practice that brings that added value to patients and to service. So I think that's vitally important. The title or the role of advanced clinical practitioner has been challenging, and I think certainly from an England perspective, when we looked at some of the change that occurred in terms of funding training, and the funding was moved towards an apprenticeship model, there had to be a role for a standard to be written. So that's where we got the advanced clinical practitioner title from. But I am hearing more and more that individuals, certainly in their day-to-day practice, are actually utilising their profession within their role title, so that again everybody knows who they are, and certainly from a patient safety perspective, they understand who they're meeting.
Thank you, Annabella. Thank you. Marianne, could I draw you in here, please?
It is those debates, isn't it? Is, are we generic or are we professional specific? In Wales, I think we're still very much more professional specific. There's a proportion of advanced nurse practitioners probably in any of the other professions, and the sort of Welsh forum that we're drawing together, we've used advanced clinical practice within our title of that forum so that people have an understanding. But from a very sort of personal opinion on there is that I do present myself as an advanced nurse practitioner or as a consultant nurse practitioner because I am bringing my knowledge advanced level, and my worry sometimes with us focusing on firstly the title of advanced clinical practitioner, we just allowing the focus to clinical practice and not our other pillars, which is what we're talking about today, is the fact that gets forgotten about, and they round you as a professional. They are the ones that make you help you develop and improve in your clinical practice because of the rounding that happens you as a with the others. But also it's losing that little bit of think like a nurse. So if I'm talking to somebody as an advanced physio practitioner, I know that physios think differently to me because they're trained differently to me. You do get that difference when you do know which profession is working at that advanced level. So I appreciate the need to have a description of what that looks like in a generic sense, but from a professional sense, I prefer using my advanced nurse practitioner or consultant nurse practitioner title because I feel it gives the patients more of an idea of who they've got looking after them.
Indeed, indeed. Paul and Diane, would you have views on this, please?
I mean, broadly, I agree. So, firstly, I think these have been great concepts and have come through and they've radically moved the professions and the narrative on. But certainly in my profession in Scotland, me and a few others have written that we should have advanced pharmacist practitioner, perhaps as the title, and it will encompass an overlap in a Venn diagram with lots and lots and lots of all these other things, but will create a version of it within our own profession that, again, the patients understand and our own professional colleagues understand. So I think these roles are great, but my preference would be that we have a variant of them in each of the professional groups. I don't think that takes away from the ones that are there, but I think it gives a bit more clarity within the profession as to what they are and how you get there and how you build it and stuff. So, yeah, agreed.
Thank you, Diane.
Yeah, I agree. I think it's important to have the profession. I mean, I think we're obviously all proud of our base professions, aren't we? So it's important to us, but I do think it's important to patients, and I also think it's important to the wider members of the multidisciplinary team, because as Marianne says, we think differently, and if advanced practice is a level of practice across the different professions, and unless we gain perspectives from the different professions within advanced practice, we make assumptions. So I'm all very much for the concept of many lenses that helps shape our multidisciplinary team from lots of different perspectives of advanced practice. So I think from a professionalism and multidisciplinary team working, I think it's really important so that we understand the difference in the roles, and there is a difference, and I think it comes back to the pre-registration. So some of us learn more about some topics than others, and so therefore that informs our advanced practice as well in our clinical specialisms at times. The three forgotten pillars, if you like, are sort of they're core throughout, aren't they? I think whichever profession, but I do think it's important, and again, like I say, for the multidisciplinary team, sort of my experience is you can make assumptions about what somebody's job is if it be just because you've not been exposed to them, so actually to gain learning and to gain benefit for the patient and for the multidisciplinary team. I think it's good to have a sort of a real mix. So no, I'm all for keeping the base profession within that.
Thanks, Diane. And you drew some parallels there again with undergrad. So Debs, can I bring you in here for your view on this? Because I think there's this underpinning theme.
Yeah. And I agree with everything that people have said, and I think it takes me back to these fundamentals that we identified in the work for workplace supervision in the Health Education England guidance. So it's about that practice context, and it's matching the professionals to that practice context at an advanced level. So it really is important you understand what's the population, and what are the needs that we're meeting for that population. But it's also why, and I think this is a related point perhaps, may not be directly answering you, Andrew, but I think it was Andrew who posed the question, wasn't it? In the HEE guidance, there was some pressure for us to replicate the medical supervision model, to have an education supervisor and clinical supervisor. Why were we not just landing that model in advanced practice? And we have changed the language slightly. We have a coordinating supervisor who follows that individual all the way through their traineeship or their development to an advanced level, and access to lots of different associate supervisors. So that allows to respond to the profession because you might need specific profession, specific supervision for your registration, but it also allows us to have supervisors beyond clinical for the rest of the pillars. So I think there's lots of ways in which we need to signal the added value that these different professions bring to the advanced practice space without neutralizing it or losing it in a sort of more generic term.
Yeah, I'd agree. Does anybody else have any comments on that? And Annabella, please do.
Yeah. Can I just come back? So I just wanted to add, so whilst we've been talking very much about profession specific, which I absolutely agree with, in terms of having that kind of generic title, the advanced clinical practitioner or advanced clinical practice, it allows a wider body of knowledge to actually emerge, which has always been silo and uni-professional. And I think that's something that the multi-professional framework has given us, a space to actually drive forward and bring, this body of evidence, which is really difficult to find because, again, you have to search through the profession-specific journals to try and look for that. There is no single space where you can bring that together currently, even now. So I think for that reason, it's really valuable. And likewise, it allows for opportunities from the wider professions as opposed to advertising, for example, roles as advanced nurse practitioner, but it allows for that inclusion actually of some of those AHP professions, the pharmacists, to come into that space to be able to actually demonstrate, allowing an advanced practitioner from that profession and what they can actually bring to that service. And going back to what you said around population needs, patient needs. So for that sense, actually, that wider umbrella allows us to do that.
Thank you. Are there any more comments, or are we okay to close that question? We okay? Colette, I'll hand over to you.
Thanks, Anna. So the next question I'm going to is from Adele. So where do you see the role of professional nurse advocate sitting in the supervision space? Is there a lesson we can apply to advanced practice here? And I think probably I'll go to Deborah first with that question, please.
So I'm going to say I haven't thought about that a lot, to be honest. So thank you for raising that question. That's one for me to add to my my further exploration. I suppose what we're seeing. So there's interesting work I think that's happening with. That I've heard James Pratt he may be listening in Nottingham talking about how the advanced practice workforce are becoming the educators and the supervisors of the future. And I think one of the challenges we have around the supervision piece, particularly as we're saying, you probably need multiple supervisors because of the complexity and the depth of the roles. And then we hear back from practice, well, look, I'm struggling to get even one supervisor. So how might, it's unrealistic to ask me to have multiple supervisors. So I suppose my thought is, thinking literally on my feet here, where we've got the professional nurse advocate and we've got the professional midwifery advocates. We've got other supervisory roles in other professions. We need to be capitalising on all the supervisory expertise we have across the system, because there's lots to learn from one another. So I don't think it's about excluding one sort of supervisory badge, if you like. And what we've tried to do in the HE guidance, again, and sorry to go back to that, but that's the one I'm familiar with, we've talked about what the curriculum needs to look like if you're working in the advanced practice space. So I suppose if you've done your training and you're signed off as a professional nurse advocate, and then you're working in the advanced practice space, what might you need to know about the other professions that you find yourself supervising there, whose registrations might be different? So I don't know, I've sort of turned that question a little bit on its head, but those are my immediate thoughts.
That's a good answer. Thank you so much. I wonder, Annabella, would you have any comments about that?
I would probably just echo what Deborah's just said in relation to that. And I think it's really important that when we consider who the supervisors are, that they have the appropriate level of knowledge and expertise to supervise and the skills required for that. So again, it's ensuring that we don't begin to exclude any individuals, but actually capitalize on who is out there.
Thank you. That's good. So the next question we can move to then is from Mary. We've got a comment here. So we need to move away from the term clinical supervision to supervision per se, as some practitioners focus just on clinical aspects as opposed to personal feelings and other issues that can penetrate a person's work. So just wondering what the panel's thoughts are on that. Marianne, did you have something you wanted to say?
Yeah, it's quite this as a conversation we've had within our organisation. So I try and think things very practically, so rather than sort of strategic. Within our organisation, I've been trying to have a forum so that we can meet and have a safe space as a group of advanced practitioners. But there's within the organisation, they also want to have where you're looking at the professional side of that. So it's trying to figure out which bit of supervision is needed and who needs what. So I've been looking closely at what we do actually need, and our clinical supervision isn't high on everyone's needs and agenda. It is actually having that safe space to talk about how you're approaching work, challenges within that environment. And we've been looking at whether or not a group model would suffice, because collectively there's lots of advanced practitioners that work in quite isolated teams. They may be one within a very medically dominated team, so it's not quite so multidisciplinary. It's sort of just one or two professional groups within there, and it's then how you afford that support and situation when actually the colleagues that you're working with wouldn't necessarily understand why you as a nurse might react to one challenge or situation differently to a physio or an OT or the doctor that they're working with. So I think moving away from clinical supervision, because that harks back to 20 years ago, clinical supervision, I remember all of that being our thing. I think that supervision around supporting your professional development, particularly with that change of identity that you go through when you transition through your training as an advanced practitioner, where you have those horrible wobbles of being an expert at 1 minute and then you become a complete novice the next. So I think the supervision side of it is better. Looking at that professionalness advocate, it's a new development. It hadn't been something that was widely known, and whether or not something, or even a coaching aspect to it rather than vision, might be something that we need as advanced practitioners. As I say, particularly working in a team.
Thanks, Marianne. Did anybody have any other
Can
comments
I
they wanted?
quickly say,
Yes, of course, please do.
this is why supervision needs to be about the resolution of uncertainties in practice, because your uncertainties can arise for all sorts of different reasons across the pillars. So we have to be a bit mindful that clinical supervision is what our regulator might call it. So you do need to be able to evidence that. But it's why we should agree with one another what we think we're doing in that space. You might have spent 10 minutes trying to find a quiet space to have supervision. You've got 20 minutes. What are we doing here? How are we resolving your uncertainties and making you feel safe in practice?
Thank you, Deborah. And that brings us very nicely to the end of the panel discussion.